Dr. Dalbir Singh is the president of the Global Coalition Against TB. The objective of the coalition is to bring together parliamentarians, policymakers, and civil society representatives to discuss the challenges of TB prevention and control in India, with a central mission to raise awareness on the need for improved TB control and formulate key recommendations. He is well respected in the international arena of TB and has extensively spoken at the national and international level on issues related to health and development from an Indian perspective with a specific focus on TB. Dr. Singh, thank you so much for joining us today. It's indeed an honor and a privilege.
It's a privilege for me to.
So I'm going to jump right in with the questions. In light of International Women's Day, what are the characteristics of TB, of the TB landscape, specifically for women, and the impact of the socioeconomic and cultural factors on gender responses and outcomes?
Nanke, I'll touch some of the fundamental issues to begin with. You know, TB is the leading infectious cause of death worldwide for women. And this disease poses a great threat to women's health security, and coupled with population growth, HIV incidence, increasing poverty that you see in India, and rising drug resistance enormously increase the burden of this disease in women. And women, particularly during the reproductive years, there is enormous increase in the possibility of progression of this disease. Now, though globally it is acceptable, and this is what the data says, there are always more men than women who are infected with tuberculosis. But that's just a biological mechanism, because there are social, cultural, and economic factors that lead to enormous amount of barriers that come in the way of accessing healthcare, and also in under notification of TB for women. TB in women creates orphans, impoverished families, perpetuates poverty, and adversely affects economic growth of our nation, or that matter every nation. Vast majority of TB deaths are in developing world where gender inequities are highly prevalent. And this proves that, you know, it's a vicious circle. You know, TB perpetuates poverty, and poverty promotes tuberculosis. So this is also one of the factors which one has to take when you're evolving policy on treatment of TB for the nation, particularly women. And there are other issues as well, determinants like malnutrition, food insecurity. They all aggravate threats such as, and also issues like rising tobacco use and increasing incidence of diabetes amongst women.
Mm-hmm.
And then, before I forget, one of the most important issues on the TB landscape for women is the issue of discrimination, social discrimination, stigma, ostracization within the community, within the family, at the workplace. If I tell you 10%, nearly 10 to 12% of TB cases in women end up in a divorce. And 16% women face huge amount of societal issues. And 25% women who are affected with TB are isolated within the families. And 18% are rejected by husband or their in-laws. And what drives this vulnerabilities? It is the stigma and huge amount of social discrimination, which still prevails in a very large part of rural India and semi-urban India. So there are cultural and financial barriers, and they are very big obstacles in terms of seeking care, which results in delay in presentation, discrimination of treatment, and socioeconomic factors, in fact, on TB control also, you know, make them as, you know, absolutely vulnerable to poverty disproportionately. Mm-hmm. And I think now the WHO, the United Nations, they've all realized that gender equity is a very important issue as far as treatment of TB is concerned. And because women also suffer, at least in India, there's an issue of literacy, an issue of being, in terms of status, being, lower in status socially than the men. And they're not educated. They're not able to even understand the intricacies of the processes of treatment, and even awareness is so low. And then traditionally, because they're in the household, they are caregivers. If the husband gets TB, it's almost established that every woman will care for the husband. But it doesn't happen, vice versa. If the woman gets TB, not in every case, the husband is going to care for this. So they're at the lowest rung when it comes to access to treatment, diagnosis, and facilities. So we have to treat it as an urgent priority globally and even nationally.
Very, very critical points you touched upon, sir. And, it's not very heartening to hear that, that is still, in fact, the reality of the situation. You touched upon, TB progression in women specifically during their reproductive years. And, we've come to notice how, women are especially left out of the conversation with regard to TB, especially maternal health. So what then is the impact of TB on maternal health that you have seen?
See, tuberculosis among mothers particularly is associated with six-fold increase in perinatal deaths and two-fold increase on premature birth and low birth weight for children.
Mm-hmm.
Then there's an issue of genital TB. Now, genital TB is a very challenging thing. First, it's very, very complicated. It's very difficult to diagnose to begin with. And it's been identified as a very, very important cause of infertility amongst women in all high TB burden scenarios. Then, TB in pregnant women living with HIV increase the risk of maternal and infant mortality by almost 300%. There's a huge burden, 300% increase. Then TB among mothers living with HIV is associated with more than double the risk of vertical transmission of HIV to unborn child. So it's almost 100% increase in the risk. So therefore, it's imperative that all these little things are taken care of when you're evolving policy. In Africa, TB rates are up to 10 times higher in pregnant women with HIV than the ones without HIV. And in high HIV burden setting, there is a study which reveals that TB also accounted for 15 to 35% of indirect causes of obstetric mortality. So this is the level of implication of tuberculosis with maternal health.
Mm-hmm. That's again very not heartening to hear, very sobering statistics. So you've sort of delineated all of these issues, and I'm going to touch upon your area of expertise over here. What do you think then, or what would you recommend as a core strategy and intervention at a policy level to combat, tuberculosis in women?
You see, in 2018, there was a special session in the United Nations General Assembly on tuberculosis. I was very honored and privileged to be there with our federal minister to attend that session. And this was an issue which was brought out by very senior health ministers from many governments around the world. And I'm very happy, taking cue from the resolution passed in the UN General Assembly, the Government of India in December 2019, the National TB Elimination Program decided to release a national framework for gender responsive approach, which was something that we're really looking forward to for many years. Because like I said, gender equity was paramount to larger success of elimination program in TB. So in 2019 December, they came into the national framework, a national policy, enabling equitable access TB care and services. And so that there is greater, and it had three fundamental issues: to work out on influences and impact of gender, secondly, to define action on gender responses approach, and thirdly, to provide important guidelines from the ministry, from the government, the center and the states for implementation. And apart from this, I I'll also touch upon a few more points that this is the main central policy, a central definition of what will give guidelines to rest of the states. But there are issues in terms of commitment, collaboration, integration. I'll touch each one of them briefly. When it comes to commitment, we have to mobilize support globally and at national levels to remove the underlying risk factors. Okay, and we have to assure that there is a gender equitable access to all the women, and there is women-friendly services, and there's in terms of prevention, diagnosis, treatment, care, and then at the collaboration level, we have to foster alliances. We have to foster strategic partnerships, you know, and and because we have to build synergies across entire health system. Because tuberculosis does not function in isolation. We realized that ourselves in the last 1 year, how much correlation is there between even COVID and TB, because they're both something to do with lungs. And therefore, we have to establish synergy in various sectors, including HIV, maternal health, neonatal, child health, okay, programs, as well as primary health care. So all these there must be synergy between all of them. And then we should not, we should very actively involve the civil society. We should involve even the communities. And I'm very glad, like ASHA works, those accredited volunteers, women volunteers, they've done phenomenal work in rural India, in villages, in various blocks of the country, in in facilitating women accessing various health services, including TB. So we must also build alliances and partnership with these kind of organizations. Then there is a paramount need to do integration, that we have to integrate TB screening and investigation into reproductive health services as well. Because if the reproductive health care, there is no element of TB component, then also there can be problem. So including family planning, antenatal, postnatal care, they all must be integrated, because so that if there is one canvas, one mosaic in which everyone fits in, it'll be easier to tap on and find more greater productivity and efficiency. Then there is a need to scale up the data collection, recording, reporting data, and data must be disaggregated. It's not an aggregated. It must be disaggregated by sex and age. Because unless we disaggregate the data, then how do we handle the women problems more judiciously? Then there is need for monitoring. We have to promote implementation of integrated patient monitoring systems for HIV, for TB, and also compile data to ensure follow-up of patients with HIV and TB. Because most HIV people, almost 85%, are very, very vulnerable to TB infection. Then we have to scale up diagnostics. Okay, world has turned to molecular diagnostics. I kept on insisting in my capacity as president of GCAP that we did a lot of advocacy to ensure that we brought molecular diagnostics in India. And today I'm very happy we have about 1,500 odd machines. But I've recommended to the government that every district in India must have a molecular diagnostic equipment for faster and accurate diagnosis of the problem. And we also need to step up our research and development, because when we concentrate on research and development, there must be women-centric research as well. Because all said and done, men and women, when it comes to their behavior and how behavior influences treatment, how it influences responses and outcomes, there is a marked difference. Therefore, when we do research also, research should not be broad-based. Research also, we have to find drugs as well as treatment, which is specific to needs of women, to women with HIV, women who are lactating, women who are pregnant, okay, women in different circumstances of healthcare. Therefore, we have to tend to all those needs. Even research must dovetail into it, many of these intricacies and details.
Thank you so much, Dr. Singh. You have highlighted some very important points, especially, the cross collaboration between sectors, a more integrated and inclusive approach to hopefully achieving a TB-free India by 2025. and dialogue and efforts that include women as well as men. Thank you so much. It was a pleasure having you speak with us, and I have gotten to learn a lot. Thank you so much.
Thank you, Nanki. It was joy sharing these views with you. Thank you so much.